Hi, Denise. Thanks so much for coming on board this morning to talk about these cases and how you got into this work. And I just want to say a quick word here is Denise. This is Denise Campbell, and she owns two physiotherapy clinics, large clinics down in Las Cruces, New Mexico, as well as a health and wellness center, in addition to the Breathing Sciences Institute. And I thought I'd ask her here this morning to give us a very brief description of how she got into this work through a patient and colleague of hers. Do you want to go ahead, Denise?
Sure. I had a friend of mine that's also a PT get hurt and hurt her pelvis, and I'm a spine specialist and see a lot of those type of problems. But as we were trying to treat her, she just couldn't seem to recover, and she had some very different symptoms where her hand would shake, her leg would shake. At first, we thought it was even like an upper motor neuron problem after she had an injection. And so I never could figure out really what was going on, but she had some extreme levels of pain, and treatment we would do, she'd feel better, but it wouldn't really stay. So I knew there was some other influence, but I really didn't know how to recognize it or understand it. And we went to a course with Diane Lee, and Diane Lee from across the room says, well, she looks at her and says, well, she's not going to get well because she's over breathing, and you're going to have to treat her breathing problem before your therapy is going to be effective. And so she put us in touch with you, Peter, and with our first introduction to a capnometer, and she went on to use that capnometer at home and work over her breathing problems. I learned about it, and then we were able to actually do some treatment that was more effective, and come to find out that the whole shaking of the hand and the arm was because of her severe hypocapnia. And when she would have that pain, or she would have things that made her fearful, or double that up with an injection into your SI joint when she was fearful of injections, all that basically was coming from her over-breathing habits and reactions.
And also, you mentioned to me how you were kind of in disbelief about how breathing could have anything to do with this.
Oh, yeah, completely, because I was sitting there, I was probably a 20-year therapist at least, and very highly trained. And I'm sitting there, and we're in the class, and she's telling me this, and I'm looking at her, and I'm like, what? How could that possibly be? And so the next thing we did was actually measure their breathing, and she was breathing between 28 and 32 breaths per minute sitting next to me, and I had no idea. So it was a very humbling and enlightening experience for me to realize that how good people can do that, and what a big effect, and how it was something I wasn't even noticing, paying attention to, and it just created a whole new set of parameters that I can look at and measure and understand about a person and their overall impact of an injury or a problem.
What's interesting is Diane Lee herself, who's an instructor in physiotherapy who travels the world doing training, actually had a breathing problem herself that showed up when she did exercise. She had no idea it was a breathing habit that was triggering all these symptoms when she did physical exercise. And in fact, she stopped doing physical exercise for some 6 months because she just was so uncomfortable doing it, only to discover that there was a dysfunctional breathing habit that kicked in as soon as she'd start her exercise. So she passed that on to you, and then you ended up working with us, with your colleague, and here we are today.
Yeah, that was, I think, I don't know, maybe 7 to 9 years ago. I was trying to figure out last night how long ago, but it's been a great impact for myself and my understanding of patients, and we've been able to help a lot of patients by understanding the influence into their treatment, their problem.
Then you had a couple of cases that you wanted to describe to us, I thought, that were particularly interesting. I think that all of us would really be interested in. One had to do with possible surgery for a patient. Maybe you could describe that one first.
Sure. Yeah, I'm I'm a McKinsey-trained diplomat in mechanical diagnosis and therapy. So at the time, I was working with a prominent neurosurgeon in a town nearby, and we had saw a lot of patients together. And he referred this patient to me, and he was concerned about whether or not she had central canal stenosis of the neck, the cervical spine. Now, the symptoms for that are you get numbness in your feet, numbness and tingling in your hands and feet, mostly in your feet first, but then it can go to the hands if it's really bad, and weakness and falling. And it's a serious problem because it's basically narrowing of your cervical spine onto your spinal cord. So it's a really significant problem that is a great concern. The lady had been in an accident before. She had already had a spinal fusion at 2 levels. Sometimes the hardware at another level starts to enclose on the spinal cord and the neck. So just to have another surgery was a big concern and something that he didn't really want to do. And he was a pretty savvy guy, and that was my job, is to, as a mechanical therapist, to check movements and positions to see if those symptoms were being caused by that. So she came to see me, and by this time, I guess I'd been using a capnometer for a while, not too long. And so I'm going through the assessment where I just do my normal PT assessment, my mechanical assessment. And sure enough, sometimes some of the movements that she had would affect her symptoms in her hands and feet. But in the process of the interview, there were some things about her that I start to see as what I call yellow flags of concern about maybe being fearful, hypocapnic, maybe having a different response, because your reflexes, your pain response, your sensitivity to movements and positions and pain levels, all those things increase when people are hypocapnic. And she had been in an accident, and so she was also very fearful. So she even looked like, one of the main things we also look at is clonus, where the foot kind of pops or their hand moves when you do a reflex change. It's an indicator of having pressure on your spinal cord. And it almost looked like that would happen, but it was like gray. I couldn't quite tell. And so I'm going through it, and all of a sudden I decided that, I really need to go ahead and check her breathing level first before I go any further. So I scheduled her in for her next visit, and we put her on the capnometer, and sure enough, she was severely hypocapnic, around the 23-ish, maybe up to 25 coming into the clinic. And so I realized now I'm not able to clearly test her mechanically because I have this over-breathing on top of that, creating some symptoms that before I would have considered as just normal symptoms. So when I was able to bring her levels up, she seemed to get better. But that's really not clear enough when you're talking about a surgery or not having a surgery and getting back to this neurosurgeon. So as I was working with her on her breathing and her CO2 levels, she would feel better. And when I'd bring her back down, her symptoms of the numbness and tingling would come on in her feet and hands, and she would start to tremble a little bit and not feel well. But I did all of this with her neck in a flex position. When you flex the neck like this, it opens up the spinal column. Because if you're worried about narrowing, you do not want to put your head back like this. That would be closing that off even more. So while I'm working with her, I have her in a position to make sure I'm not involving what would be her spinal stenosis provocation. So I have her neck slightly flexed. But as I get more convinced myself that this is from her CO2 levels and not from her neck, I decided to test her definitively because I needed to get back to the doctor. So instead of sitting her in this position, I got her breathing level up to normal and to where she had no symptoms. And I actually placed her in a position laying down on her back with her head back that would cause the narrowing in the spine if that was the cause. And so I put her in that position, and kept her breathing level up, and she didn't get her symptoms. So then I made her overbreathe in that position and brought on the symptoms, all of them, and then we brought her back up, took the symptoms off, still staying in that position. So that gave me a very clear and definitive understanding that her symptoms that were mimicking central canal stenosis and spinal cord pressure symptoms in this patient were from her level of CO2. So I was able to get back with the neurosurgeon, say, no, we do not need to do, I do not recommend surgery. I think that we need to help her with her fear factors, her breathing levels, get over the accident and some of the other, learned issues that she had, and she went on to do quite well. Even though in her mind, she actually wanted the surgery. It took me quite a bit of time to convince her that those symptoms were not from her neck, because she'd had something like that before. So anytime she got anything like that, she would make that assumption. And when she made that assumption, that took her back to her prior surgeries and her accident. So there was that whole vicious cycle of learning that goes on with this patient that had to be broken. And I'm very thankful to have that ability now. I wonder how many people fooled me before. And it's very concerning when you're doing something like recommending a huge neck surgery to a neurosurgeon that you don't have all your facts in line.
Well, thank you. Is there anything more that you might say about your conversation with the patient during the time that this discovery was made?
Yes. So it's not so much I was looking at what I was doing as a PT, but what was more important for her to understand that and to get that across. And so why I had explained to her about her neck, because she knew initially that let's don't put your neck back because that could be a problem or that could activate this more. So while she's laying there, I said, look, we brought your breathing levels up. We clearly showed you that when your CO2 levels go down, your symptoms come on. When we bring your CO2 levels back up, they go away. There's this very clear correlation. So I'm going to let you decide. So we're going to put her in this position. She's watching the monitor. As her symptoms go, as her CO2 levels down, her symptoms came on. So I said, okay, we've had you laying here. We haven't moved you. What do you think brought your symptoms on into your hands and feet? And she said, well, I guess it's my breathing, but she didn't really, it wasn't a confident thing. So I said, well, let's overbreathe and let's see what happens. And let's see if not only can we turn it off, but turn it on and then turn it off again. So then we had her overbreathe. Her symptoms came back on. So now you have your symptoms, but your neck still hasn't moved. You're still in the very same position that you were. Nothing's changed except your CO2 levels. And now you have your symptoms again. And she started, yes, so I see that that's from my breathing. I said, okay, well, that's going to happen if it's from your breathing. Let's turn it off. Let's show you how to turn it off. So then we went and brought her CO2 levels up, and her symptoms went away completely. And she had like a complete, the whole revelation of the understanding of cause and effect now was very clear for her. And she said, yes, I do understand now. This is not my neck. This is my breathing response, and I do have control over that. So really working on her locus control and that understanding of cause and effect of her breathing, taking her neck out of it.
Did she have any comment about the impending surgery that was being considered?
Yeah, it took her about a week to kind of get over that point of needing surgery because there were other factors. She was starting to build her identity around this accident. She had a lawsuit going on. She had a lot of things, but she actually very clearly came there, and I was able to kind of help her understand what a great thing that was, not to have that surgery at a young age and how she could easily control this and get back to the other life she wanted to try to get her out of that. But that took 2 or 3 sessions.
this is a good example of how a person can build an identity around a habit, particularly a habit that triggers all kinds of symptoms that serve her in certain ways. This is an example of secondary gain, where the person doesn't realize that what they've learned is setting up a situation in which they receive attention and other kinds of things that may then perpetuate or then build a new kind of self-identity. So that's a beautiful example. Thanks for that.
Sure. The other one comment I would say is it allowed me to introduce this to the doctor, because the doctor, the neurosurgeon, said, how did you figure that out? Because this is the type of patient that he would have done surgery on, or I would have kept doing treatment on, and they would have never been better. They were actually worse. So he was very happy about that, and that he did not have to go there, because that could be a potential lawsuit or any other big problem. And so he was able to.
Beautiful example of the interaction of physiology and learning, and how learning takes place in physiology, and how learning habits are embedded in physiology. A beautiful example of that, and it's really what we call a behavioral analysis, in this case of breathing behavior.
Yes, and then I was able to take the breathing behavior and utilize that in my field, what I know how to do, and put those two things together to get a very clear picture of what is the cause of the symptoms. And that's, I'm sure anybody could do that in their given field.
So maybe you could take a little time and give us a description of the second example that we went over recently.
Sure. So I had another patient who was a gentleman that had had spine surgery. And he was coming to me, and he really wasn't doing well, and he had a very high pain level, 8 or 9. Had a 2 to 2.5 year history of severe pain before the surgery. He was a workers' comp patient. So a lot of times they put off these surgeries so long, these patients suffer so long, that after they have their surgery, it's nothing really changes that much. But he was a little bit better, but he would come in and he would talk about feeling nauseous and actually throwing up. And first he said it was because his pain levels were so high. And so we started to bring those down, and he would start to feel better. He would feel better with his symptoms, but he would always say, well, I'm on the medication. And we started talking about, okay, well, when your pain goes down, your nausea goes down. And he would say, yes, that's because I'm on pain medication. Even though he would come into the clinic at a high level on that same pain medication and come down as we would work with him and talk with him and do therapy, same level of medication. So there was a little bit of not quite understanding the concept of his pain medication, but he was very concerned about getting sick. So he decided that, well, in the course of the treatment, I was like, well, you know what? I don't think your pain medication's really working that well, because you can come in at a 7 or a 9 and then go to a 3 and then go back up and feel nauseated on the same time period of your medication. So why don't we try not taking your pain medication? Because he also had the idea that the pain medication made his stomach upset. Because why would you have to reason, why would any other reason that you would constantly have nausea and throwing up as a patient? So I convinced him to, let's just don't take your medicine on your next visit, and let's look and see what you have. So he came in. His pain levels were very high. He said, my pain level's really high because I haven't taken my medicine. But he was nauseated and sick as well. So put him on the capnometer. Of course, he was severely hypocapnic at that time. And we brought his CO2 levels up. His symptoms started to go down. He started to calm down. And his nausea went away. It went away and disappeared. And so I showed him that, and I started to see that his breathing, he calmed down, and he could really kind of think and rationalize at that time, because he had to get these people in a window of this. And then I was able to actually know that my readings and what I was seeing on the capnometer were real, because the opioids on board. That's always an issue with us, because if they have the opioids, it skews what we see on the capnometer. So he at least started to realize that. But again, he needed to understand why he was having this sick of his stomach, because for him it was a big issue to get off his medication so that he wouldn't be sick of his stomach, and then he was going to have his pain. So he's in this vicious cycle. So I'm realizing that all of these symptoms are from his overbreathing, but the patient needed to realize it. So I said, well, now that you're feeling better, let's overbreathe again and see if your nausea and your stomach problems are from this. Could possibly be from your overbreathing. So we did that. We had him overbreathe again. And we took him pretty low, because once he got into that, his pain came on. So his pain down his leg that he used to have, when he got below 25, would actually come on and go down his leg, like the symptoms he had before surgery. So he would get very upset. He would get the pain would come on. He would think that the surgery was of no use. You know, all these thoughts are going on into his head. So I would get him to about 28, 26, and his pain in his leg would come on. So he would immediately overbreathe down below 20. Just himself. I didn't have to do anything, because it's a response to his pain. Sure enough, once he got below 20, he would start to throw up. His nausea would be so high, he would start to throw up in the clinic. And so he did that, was able to say, okay, we're going to work with you and bring that back up just like we did before. And as we brought that back up, his nausea subsided instantly. All of that came up. His pain stopped. And as we got up into the 30s, all his symptoms went away, but just a dull ache in his back. And so he would start to be able to, then I could ask him the question, well, what do you think did that? And he was starting to see. So we did it again, but this time he understood that, I made sure he understood that the pain in his leg was coming on because of his CO2 levels, and not to react to that. This wasn't his back redoing, because he's just sitting there. I'm like, you're just sitting here. Your back is not, nothing's happening with your back. And to get him to trust me on that. So we did it actually one more time, because it's not that I have to know why he's doing that. He has to know. And I find that one time doesn't do it, even though there's not too many patients that I'm going to go ahead and make throw up again, or at least gag in order to get the point. But you might not have too many patients to return if you do that too often. But anyway, I have confidence in that. So we actually did the same thing, had him overbreathe. He comes down. I was able to see at what level his pain went down his leg, so I could help him understand that in the future. His nausea would increase until finally he would start to gag as it dropped below 20, brought that back up. And again, the light came on for him, and he's like, I'm doing this to myself. I'm like, yes, you are. And it's just because of the response to everything you've had. And I asked him, did this have anything to do with your medication? He said, well, no, I guess not, because I don't have my medication with me and I haven't taken it. So he was able to, one, see it was not his medication, two, see it was his CO2 levels, and then the next point is, the third point is that his pain would come on at a certain level of being hypocapnic. And if he actually stayed out of that level by focusing on his breathing, he didn't have to have any pain, any nausea, anything at all.
I mean, there was the vicious circle part of it, because as soon as he would start to feel the pain because of the overbreathing he was doing, he would then begin to overbreathe radically, which would then produce the nausea and the vomiting.
Yes.
And then so you get caught in that circle. So these are both beautiful examples of how we do an assessment and sort out the physiology from the learning. Of course, learning is physiological, but how learning as a physiological process gets involved in a particular physical challenge that a person may be having. So these are beautiful illustrative cases, and I want to thank you so much for taking the time to describe them to us.
Sure, no problem. They've been very insightful and helpful to me in our treatment. And now we see this all the time in therapy in our clinics, and our therapists have all learned maybe not to that level, but we definitely can recognize when it's a factor and how to help the patient understand it with the capnometer.
Yes, it just takes, you know, dedicating yourself and getting the experience you need to be able to do this sorting out that you've just described to us.
Yes.
So thanks very much, Denise. Really appreciate it.
You're
and
welcome.
see you very soon. Have a
All
good
right.
trip. Have a good
All right.
trip.